three parts, naso, oro, and laryngo. Here's the best way to describe these. If you look in a mirror, open your mouth, stick out your tongue, and say, ah, and look straight back, you're looking at your oropharynx. If you got a dental mirror and pointed it up, you see your nasopharynx. If you use the dental mirror and pointed it down, you see your laryngopharynx. So the area just above where you can't see is naso, and just below you can't see is laryngo. Nasopharynx has some interesting structures. One of the ones you probably hear about is the adenoids with lymphatic tissue. The oropharynx has the palatine tonsils, which you'll probably hear about. When people say they have their tonsils taken out, those are the ones that they usually mean. And they'll say, and I have my adenoids taken out as well. It's because they're very close to one another. The laryngopharynx, these have the lingual tonsils, and those aren't as affected as much. You can kind of think of tonsils as being a lot like lymph nodes as far as their job, that they help to sort out infected cells, help to sort out infectious agents. The problem with them is that they can become overrun, sort of like putting too many prisoners in a jail or in a prison. And after a while, someone will say, you know what, there's only 50 guards here and there's 10,000 of us. If you do the math, it's a no-brainer. And so, of course, if that happens chronically, what do? Take the tonsils out. No, tonsils, not prison, sorry, yes. I'm sorry. We're back on the tonsils again, taking you back there. And the people who have their tonsils taken out live a normal, healthy life. You probably wouldn't even know somebody had their tonsils taken out, right? Unless they included it on their Match.com profile.
I had mine out last year. It sucks. It's on my profile.
Did you really put it on your profile, though?
No.
Oh, okay. Because that would have been odd. They're single. What? No. I say this because people will tell you the appendix has no purpose, right? They'll lie to you. They'll say the appendix doesn't do anything. No purpose for it. That's not true. It acts in a very similar way that tonsils do. But just like the tonsils, it can get overrun. It can become more of a problem than it's worth. And that can cause a major problem. The tonsils usually are not life-threatening, however, and that's the difference. But if you take the appendix out, you can live a life on Match.com without that organ as well. So this is why there's some confusion about that. Years ago, decades ago actually, there used to be a time where if a surgeon was doing abdominal surgery and they found the appendix there by chance, they would take it out. They would figure, well, since we're in here, you might as well get it out now so it doesn't cause any problems. They don't do that anymore. It just isn't. If it's not broken, you don't fix it, right? So, just like you can get your tonsils taken out and still live, appendix too, doesn't mean it doesn't have a purpose. Okay, you can see this area here. Passageways into the middle ear called the eustachian tube. We did talk about this, I think, on Saturday, right? The senses. Eustachian tube. This is the tube that moves into the middle ear. This is how those little infectious agents go from the throat to the ear. That's why these kids always get ear infections. Remember, their eustachian tube is shorter and more horizontal, whereas ours is longer and more vertical, ours being adults, of course. Oropharynx lined with stratified squamous epithelium. Laryngopharynx, we've already talked about this. Water, food, and air pass through laryngopharynx. That's the last part of the throat, and it branches off. The voice box, larynx. We already talked about that a little bit. Cricoid cartilage lies below it. Cricoid, have you heard of cricoidectomy? Cricoid pressure. Glottis is the opening that leads to the larynx and eventually the lungs. That's why that little flap is deep, lungs. During swallowing, you're going to soft palate and move back and up to help keep things from going up. The epiglottis moves down. So that way we have food and beverages going to the place they're supposed to go, like pizza. Because tomorrow is Pizza Friday. Okay, epiglottis, we've talked about that. Do you know what the uvula is? We talked about the uvula? The uvula is that little punching bag that hangs down. You open your mouth, take a tongue, say, ah, that little part right there. And what that does is that's actually the first thing to initiate the gag reflex. So the body says, this is a bad idea. Upper respiratory infections. Oh, look at this. This is the guy causing that bacterial infection. The group A, beta hemolytic, Streptococcus pyogenes is the one causing the strep throat. Viruses cause lots of the upper respiratory infections. Not surprisingly, viruses cause a lot of things. You can see strep throat. It's a pretty good indication when you see it on those tonsils, especially on the patients that have the tonsils. You'll see these little pockets of pus. And it'll be white or yellowish white on the tonsils or even on the back of the throat. The patient will complain of having a terrible taste in their mouth. You will complain about them having terrible breath and, of course, sore. That would be enough to make a sort of a clinical diagnosis, do a rapid strep test to confirm it. Lower airway starts below the vocal cords. You want to, that's making, these are, making sure we have some sort of airway when nature takes it away. You guys know how to intubate yet? Someone? Have you done it for real? No. No? You have? Okay. It's a bit of a trick. I was in a good position because I learned how to do it in the operating theater, and that makes it much, much easier because I have a patient who is now unconscious with a perfectly patented airway, no problems with it to begin with, and I've got all the time in the world. I've got a solid minute to work on this. So that's how I learned. So it was really easy. I do not envy anyone in here when you guys have to learn how to do this or actually do it on patients when you really have to try to fit that through there because it's a trick. It really is. Let that be. Once you get it in, then you're not even sure you're done yet. Because after you get that tube in, you put a bag on it, what do? You have to listen, right? Because when they're squeezing that bag, you want to hear shh, 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 shh. If you hear, then you move the stethoscope down here, right? And then if you hear it, maybe I'll start over. Tracheostomy tube, this is a more permanent opening. The cricoid thyroidotomy is not, typically. Disruption of oxygen has fatal consequences. I don't know if you knew that. That's going to be on the test. Tracheobronchial tree, because it looks like an upside-down tree. From the vocal cords, air enters the trachea, extending to the 6th thoracic vertebrae. C-shaped cartilage. Remember? Okay, here we go. You can see the cutout for the heart on the left lung. What is not as obvious in this picture is the division, the corona, right here, the bifurcation, the break. Because the right side is actually a little more straight up and down than the left side. Which, if you think about it, makes sense, because the heart is right here. It's taking up some room. So this has to kind of kick it. The left main stem bronchus here has to kick over a little bit. Why is this important? Think about that kid playing with that toy. Put a little piece of toy in their mouth, and then goes. Much of the time, you will find that on this side, because it'll be more likely to go straight up and down than to pinball over. Okay. Site of bifurcation called the carina. Bronchi must branch into 5 lobular bronchi that correspond to the lobes of the lung. Okay, look at the anatomy of the bronchi. Not surprisingly, we have cilia and we have mucus. We're going to trap and we're going to move, and specifically trap and move up to move out. We have smooth muscle, and then we have cartilage. When we get down to the smallest branches, we don't need all that cartilage, but we do need a lot of that smooth muscle. That's where most of the smooth muscle contraction and relaxation takes place in the bronchioles. Hold on, I need a back of files. This should only take a minute. It's not the same. Okay, not the same. All right, so you see that. Over that. Endotracheal tube placed too far in the lung. You end up having one lung getting ventilated more than the other. Just like a tree, we have one big trunk that branches off into a couple of major trunks, which branch off into smaller branches, which branch off into smaller branches, which branch off into smaller branches, eventually getting to the bronchioles. Terminal bronchioles, this is where we are going to start to find the alveoli. Talk about the pneumocytes, I think, in a little bit. The little balloon-like sacs, the alveolus, obviously has to be connected. These are easily thought of as looking like a cluster of like grapes, but actually acting more like a bunch of balloons that have the ability to expand to an extent and collapse to an extent. Now, the problem with that, if you get a whole bunch of balloons that are expanding and collapsing, and you fill the whole inside and the outside of these balloons with a sticky substance like mucus acting like a glue, what's going to happen is they're not going to have the ability to expand. They're going to lose that surface tension, and they're going to be stuck. They'll be solid. So we have cells, I think we'll get to them in just a little bit, that produce a slippery little detergent-like substance. It's a protein-fat combination, which is called what? Surfactant. That coats the alveoli so that they can expand, increase their surface area, and therefore obviously get the oxygen exchange to occur. This is not something that is created from immediately when the lungs start being made in the utero. This is something that doesn't occur until about 22 to 24 is when we see surfactant being produced. So if a baby is born really, really premature, or as it looks like is going to be born really premature, the doctors will say something like, well, the lungs aren't functional yet. What they really mean to say, it's not that the lungs aren't functional, like they don't have all their parts, but the baby's not producing surfactant yet. which means as soon as you take that baby out into this environment, and the baby tries to expand those alveoli, they'll get one, and then this, and then that's it. Breathe in, go, and then that's it. And you can't force that open, because if you try to force that open, there's no rupture. That's why we want to keep babies cooking for the recommended time. We don't want to take them out early. I try to explain this to people. It's like if you bake that chocolate cake, and you're supposed to have the cake in the oven for 25 minutes at 350 degrees. I have no idea just how long cakes are baked for. I just eat them. But for 25 minutes at 350 degrees, if you take that cake out after 15 minutes and try to finish it in the microwave, it's going to be different. It's not going to come out the same. There's going to be serious problems.
There's nothing wrong with microwave cake. He's made it.
Well, then, challenge accepted. Bring it in.
You don't have to microwave it.
You know, don't talk about cake and then stop talking about cake.
Can't have it.
I want to have it and eat it. A stupid comment. Who wants to eat their cake and eat it too? Come on. Everybody wants to eat their cake. Why would they want to have it and not eat it? Oh, cool. Say something like that.
I said it.
Yeah, exactly. Alveoli, only simple squamous epithelium. These are very, very thin, and there's obviously plenty of them. You can see how they are clustered together at the terminal bronchiole there, and the capillaries surround them as the red blood cells pass through in single file, picking up oxygen, the blood is dropping off carbon dioxide. Yeah, and because I realized that, and we're almost at a break time, I realized we only have 2 hours left of class when I was coming back, before I was coming back. So I was able to look through the test and get the stuff that I want to make sure that you guys are able to move. So that's why if you see me skipping a little bit, I want to make sure we get through all the information. Bronchiolitis, have you heard of this yet? Do you have any children? Anybody you know have children? You will probably hear of this at some point. Most commonly caused by a type of virus, respiratory syncytial virus, RSV. It is usually not horrible. It starts out looking like a regular upper respiratory infection, but it could get worse. It could actually hospitalize the kid and even ventilate them later on if they need it. What kind of antibiotic are we going to do for this? It's a virus, so
Some steroids.
all right, let's take a quick break, and we'll come back and finish.